Good morning. Thank you, David. Thanks for having me. A couple of things that I wanted to talk about before we get started. First, it's great to be here. It's great to be in the epicenter of population health. Who would have thunk that we would have said Philadelphia is the epicenter of population health? I'm from Baltimore, so maybe there's some Philadelphia envy, but whatever. I want to thank President Klasko for holding this. Was that not the most refreshing speech by a university president that you've ever heard? I mean, just absolutely phenomenal. There was some news yesterday. I had the great pleasure of doing a little interview with David. We talked about a joint venture partnership between my firm, Sage Growth Partners, and the Jefferson School of Population Health, the preeminent school of population health in the country, really around driving an innovation agenda and commercializing, socializing, and mobilizing all of the incredible intellectual property that's here, not just in the school, not just what David's built, but what David's proliferated. I mean, the ability to have this kind of discussion on such a broad basis is really incredible. So again, we are thrilled to be here. I have to thank Alexis Scofalos for really driving that on the Jefferson side for us. She's been an incredible partner, so thanks there. So a couple of disclaimers before I get started. First, the firm's called Sage Growth Partners. We are based in Baltimore. We're a healthcare strategy, technology, and go-to-market firm. I can't define it better than that because, it's things are moving so rapidly. There's a little picture of us on the inside of the booklet, so please look us up, and we'd love to have dialogue. In terms of disclaimer, and I'm a slow builder by the end of this, I will be sweating profusely and bouncing all around, but I have to tell you, just to be prepared, I do have ADHD, severe, and I'm not medicated. I've been described kindly as dogmatic. I'm the best pisser offer in the world. And thank God there's a gun check at the door. I have 40 minutes, and I've never done anything in 40 minutes. So usually I don't get kicked off the stage because I'm a little intimidating, but we'll see how things go. I have a hypothesis. I think our firm has a hypothesis, so you'll have to bear with us a little bit and sort of wade through this. And the analogy is obviously with the Industrial Revolution. We think the business is pre-industrial, and I think you're going to hear from me today. I'm going to overwhelmingly talk about delivery system reform, provider dislocation, payer and financing, and that's not meant at all as a slight to all of the folks that are talking about all of these wonderful topics around e-health and more deeply around consumerism and a connected world and sensors and monitors and all of these wonderful Internet of Things concepts. We love those concepts. We live those concepts as a firm. One of the things that I believe, however, is that if we don't fundamentally sort of change the way the system is structured, and in particular the delivery and financing aspects of the system, we're really going to be up a creek without the proverbial paddle. So I want to make sure that we talk about this. So my goal for today is to define this concept of pre-industrial a little bit, is to then, and this is sort of where the bright light ends and we get dark and gloomy, talk about intractable problems. And we have significant headwinds that all of us are familiar with. So I'm not going to be telling you anything that you don't know. I may be telling you this in a way that's packaged a little differently than you've thought about it, but it's sort of like the intersection of macro environmental factors meets the street meets pragmatism. So I want to talk a little bit about those headwinds because I think we have to face those headwinds head on, and I'll share some stories with folks that are quote unquote experts in the business that really have me walking away, shaking my head. And then the notion is, well, as I've thought about this a little bit, sometimes you actually do need a blunt force object to the head to really sort of change behavior. I'm talking metaphorically, of course. I think the second thing about this is, in my last 17, 18 years, I've taught health economics at Hopkins. We've had a great, I'll tout the program, a great joint venture MBA program with our School of Medicine and the Business School, and I've taught a lot of physicians in that time. And we've been talking about And I teach a micro class, and we talk about the power of price, and we talk about the power of consumerism. And the fact of the matter is, everybody in the class says, well, we don't really have consumerism in healthcare. What's really going to happen? What's really going to change this game? And so I'm going to talk a little bit about what I think is the rising role of consumerism, but I think more specifically, we have to talk about payment redistribution. This is something that's really fundamental. If we're going to change this system, then we have to get the provider organizations rowing in the same direction around a value-based care agenda. And so I had breakfast this morning with somebody who said, we're all in. We're all in around value-based care. We've changed the way that we do our business. We've transformed. How many people have heard the term transformed? And you wonder, what the heck does transform really means? Well, transform, in my mind, at the unit level really means that you're changing the way you practice. Let's say a primary care physician, changing the way you practice, changing the way you staff, changing the way you structure to really be focused on driving the Berwick triple aim, right? Better care at the point of care, critical, closing gaps, identifying early, counseling, monitoring, so on and so forth. Better care at the health status level, at the population level, which requires us to change our paradigm because we always talk about patients. And one of these difficult pivots is going to be, how do we go from thinking about patients to thinking about consumers? I think it was very telling in the early days, and certainly still to this point in this ACO journey, and I'm not a big fan of ACO at all, so I'll just sort of dispel that right now or put that out right now. But one of the early feedback we got from ACOs was, we have a lot of time attributing our non-patients. We have a really difficult time identifying the folks that aren't in our system. Okay, well, you would never hear a retailer say, I have a tough time identifying the people that aren't using us today, right? So this is part of the that's tough to say, C, change, shift that has to occur, number one. Number two, consumerism is here, it's growing, and as you'll see from some of the data, it's sort of disarming because while we go through this process and we're doing a little sausage making, people are really getting harmed. On a financial basis, people are getting really harmed. And so the question is, how do we drive consumer sovereignty in a way that doesn't bankrupt more and more folks? So that's a key part of this discussion also. So what are these pre-industrial symptoms? And again, you'll bear with the analogy, and you'll give me a little bit of breathing room here. But I think that these things line up. I was on a panel, or I was the facilitator of a panel about 6 years ago. It was a GE healthcare panel, and the president of GE Healthcare and the way GE operates, I don't know if there are GE people in the room, the way GE operates is the leadership development program is basically rising, aspiring leaders in the organization move from one GE business to the other, and they learn agnostically a lot about different businesses, and they learn their discipline. And so this fellow was an engineer. His name's John Deneen. He was an engineer, and he grew up in the GE organization, and healthcare had been his last stop in the organization. And my job in this panel, which was a really esteemed panel, was they said, Don, we want you to identify all of the headwinds. We want you to identify all of the macro factors. We want you to identify the big challenges, sort of like what I'm going to do now in a second. And so I started to go through this litany, and all of a sudden I could hear John Deneen say, yeah, we lived through that in the locomotive business in the 60s. Yeah, we lived through that in electronics in the 70s. And so this was sort of, reiteration to me that, these challenges, these problems, they've been here before, right? We've lived through these challenges in other businesses. I remind people that in now healthcare, I just read the Alterum briefing this morning. Healthcare ended last year about 18%, 19% of GDP. Okay, so put that aside for a second. In the other 80% of our economic lives, we rely on markets to raise our standard of living and drive efficiency and so on and so forth. We don't really compel healthcare to do that for us. So these industrial symptoms are really important. One is there is a very high degree of variability, and you'll always hear, and I taught physicians, it's very refreshing when you're teaching physicians because our format was a weekly cohort format, and each and every week I was reminded I was the dumbest person in the room. It was always a reset, and I really just enjoyed it. The physicians would tell us, well, this is a different business. We're dealing with humans. There's a lot of natural variability. There's counterfactual information, all of these other things. Well, folks, let's put our arms around the variability that we can understand and identify and control, okay? I will give you the variability that we can't. Let's get our arms around the variability that we can. So a high degree of variability signals to me that we've got a pre-industrial business. Number two, there is a tremendous lack of transparency. I'll share more with that later. There's an economic term, information asymmetries. Information asymmetries are abound. And now, in the Medicare Advantage program, as an example, and all across healthcare, we're doing risk adjustment. I had a very close friend who ran a Medicare Plus Choice, if you remember in the 90s, a Medicare Plus Choice program, which was, this is going to be a little technical, but you were only paid on age and sex cells. There were about 12 payment cells. And so basically a 74-year-old female was, from a payment perspective, the same 74-year-old female regardless of her clinical disposition. And this friend of mine ran this program, and he said, I was trying to figure out how to really, basically stress test members, and so I set up an enrollment office on the third floor of an old bank without an elevator, and if they could make it to the third floor, they were able to enroll, and if they fell out, then we would help them, of course, but they wouldn't earn enrollment. That's addressing information asymmetry, right? So this challenge of how do we really uncover what's out there? So a lack of transparency and information asymmetry is a big issue. I would argue that there has been largely opportunistic innovation, that the garage movement is just starting to come to healthcare, and we've had mostly innovation around therapeutics, and it's been mostly chasing the money. Okay, and I'm a big Clayton Christensen guy for folks that like Clay Christensen, and I think it makes eminently good sense if we can perfect diagnostics. We can do so much downstream to change the delivery system, to practice at top of license, to do a whole number of things if we could really accurately diagnose people. So there's not been enough investment. I'm hoping, frankly, that this payment model change is going to drive some of that. We have still very limited division of labor. We don't practice at the top of license, or we practice well below in the case of physicians. Why does a physician need to treat a kid with an inner ear infection, right? We can predictively diagnose it. We should be able to treat it without a physician's intervention. I would argue that fee-for-service payments, right, have been part of the regulatory barrier there. I mean, in other words, if you have an incident to reporting requirement for those that are in the business, you have regulatory requirements to deliver care in a certain way. I want to unshackle those things and try to drive better labor allocation. Healthcare is the only major industry in the U.S., if you look back to 1990 or 1980, where the growth in the business has been completely driven or overdriven by a growth in labor. Okay, in other words, in most other industries, if you look at manufacturing, most of the growth in manufacturing has been driven by labor productivity gains, technology-infused gains that are driving better output per labor hour. Healthcare, all of the growth in healthcare has been driven by adding headcount. And I think that it's pretty interesting. If you remember back to, I think it was February 13th, maybe, I can't remember the exact date, 2009, ARR Day, President Obama said two things that I thought were interesting and contradictory. He said, number one, on one hand, we want to bend the healthcare cost curve. I think he meant presumably we want to bend it down. And this was the day he was announcing $800 billion in Keynesian stimulus. Sorry for that insert there. You'll sense my ideology. But so on the one hand, we need to bend the cost curve down. We need to drive more efficiency. And remember, we were going to spend $800 billion. On the other hand, he said, we need to invest in industries that can drive job growth. So guess what industry got most of that investment? It was healthcare, right? So we're making a $200 billion investment in basically a jobs plan in healthcare, and then we see out of the other side of our mouth, let's bend the cost curve. Now, I'm not arguing that a job strategy is not the right strategy, but we ought to decide, do we want an efficient business and an efficient market, or do we really want a jobs industry? And so that, I think, question is still outstanding. Very marginal quality. We hear horror stories about this all the time. I am not the expert on quality. David is, and David tells some unbelievable stories about disparity, and I think that also extends into health status, inequality. And I was always struck in the 90s, I'll never forget this statistic, when I was looking at data and I saw that the Medicare program spends for a 74-year-old and female in Omaha, Nebraska, I think it was like $370 at the time, and that same 74-year-old female in Miami, the Medicare program was spending about $1,100 a month. That was in 1997. Okay, there is no way in hell those people are so different. All right. So how do we get here, in my humble opinion? Humble is questionable, but we'll see. I think, this goes back to 1965. Again, you could shoot me down, but I have the stage and you can't ask questions right now. The Great Society, I think, created great gaming, right? This fee for service, this role of Medicare really as much more than just a payer, much more than just a monopsony. Medicare as the regulator, Medicare as the driver that all of the other industry followed. There was a great gaming, and this volume mentality was really driven, and it's been driven over the years. And in fact, we've built, if you talk to primary care physicians, how are you going to enhance your revenue? I'm going to build ancillaries, right? We talk to specialists, how are you going to build your revenue? I'm going to partner with the hospital. I'm going to build this. I'm going to build that. It's been this sort of arms race dynamic. Third-party insurers have really fallen down, not been, I think, broadly speaking. I don't blame them for margins. I hear people all the time talk about all of these health plan profits. I think if you look at the margins over the last 10 or 15 years of the for-profit health plans, they aren't egregious. Okay, so I'm not an apologist for health plans, but they're not egregious, number one. And number two, statistically, probably 95% of us all own a publicly traded health plan in our retirement portfolio or some other investment portfolio. So we are sort of dichotomous minds about the role that health insurers play. There's been no consumer sovereignty, right? As recently as a couple of years ago, consumer spending at the point of care was somewhere around 13 or 14%. Now, remember, think about that. Think about your favorite place. I always say to people, if I had a Best Buy, co-insurance card, and it was 15%, co-insurance, I would go crazy. I'd react, accordingly. I think that we've reacted accordingly. And I love this concept. Dave Chase, who is at WebMD, who writes frequently for Forbes and other places, really a smart, intuitive writer, talks about the fourth party. Okay, so we've got third-party payers. The fourth party has really been the employer. The employer is about 50% of the game, or a little bit more, although dwindling. And I would say employers have been largely complicit for a long time, out to lunch. And I think the question becomes, are employers, and maybe they are starting to change, and I think there's some evidence they are employers really going to change their role in the business? And then finally, we've talked about government's role. It's really difficult in this pluralistic system where government is about 50% of the spend in all activity to sort of get see your way toward accountability, but we have to drive there. So in my mind, quickly, industrialization would be any of these things and a whole bunch of other things, of course. But the red line is really about this notion that, look, if we weren't to spend not one net new dollar on health care, okay, not one more dollar. And by the way, the run rate for health care right now in the U.S. is over $3 trillion. It's the first time in history that run rate, meaning if we looked at forward 12 months, we're going to spend $3 trillion on health care in this country. Our healthcare spending is half of all global healthcare spending, okay? So we're 3% of the world's population. We're half of all health system spending. If all we did was repurpose and better use the $1 trillion, we would be so far ahead of the game. Because my argument is that predominantly with all of the factors I just showed you, there's so much spent where the marginal benefit just barely, if at all, exceeds the marginal cost, and that's not really a good thing. So industrialization is not, I want to be careful, this is where I get on my capitalism soapbox. Capitalism is not crony capitalism, right? This is not complicity with big business. Industrialization is not consolidation. Been there, done that, folks, right? We've seen hospitals consolidate rapidly at the end of the 90s, and the outcome wasn't good, and I'll show you a little slide a little bit later. We're not suggesting that we need cookie-cutter medicine. Standardizing does not mean taking out the art in the business. We're not advocating a mechanism to drive physician employment or the new HMO model or any of these things, and we certainly don't want to be an inhibitor to innovation. So let me talk a little bit about these intractable problems and there's probably 6 or 7 of them. And this is the depressing part, and we'll just suspend reality a little bit and pretend we're happy about this. But so problem number 1 is the spending. We've talked about the spending over and over again. I just mentioned the Alterum study. Alterum just did an analysis. Looks like 2014 year-over-year growth was at 5%. So if you look at this stuff, we've had a couple of years of really moderated growth, right? 3.9, 3.7%. We're now at 5, and I think for the foreseeable future, we're going to be at 5+. And the big tailwinds behind this are the economy's improved, drug prices, expansion of insurance, a lot of expansion of insurance, including Medicaid expansion, right? So it's very difficult, by the way, to expand insurance and lower spending. I don't know if you figured that out, but there's a dichotomy in there. So, the projection is easily by 2025, we'll be spending left unabated $5 trillion, and we're consuming more and more and more of our gross domestic product. This limits government's ability to do other really beneficial things like bailing out automakers, bailing out banks, so on and so forth. The second part of this, of course, is are we really getting value? And I would say this in 2 contexts, right? We don't ever bang our fists, and so as you may surmise, I'm an ice cream aficionado. I don't ever hear anybody screaming, we're spending 0.5% of our gross economy on ice cream. I decry this. This is a travesty, etc. Well, part of the reason is that would be ridiculous, and I don't even know if it's 0.5%, but part of it is because we make those choices out of our pocketbooks, right? We choose to spend those dollars. Part of, I believe, the outcry around healthcare spending is the fact that we feel like we are removed from the purchasing decision, okay? So we can't really have it both ways as consumers. We can't have benign neglect and then all of a sudden scream that our money's being misappropriated, but in a sense, that's what we think is happening. But on an outcomes basis, we're not doing that well. And this is one indicator that, I think it's tough to read this as single-threaded, but we're 16th or 17th. This is a slide that David shared with us last week when we were together in terms of, this is life expectancy, but a number of public health indicators were marginal at best. Problem number 2 is, as I mentioned, consumerism is coming, although, again, I think we're challenged how to get there. Now, this is really an alarming slide, because if you look at the upper 2 graphs, the green, the light green and the dark blue, those represent growth in health insurance premiums and growth in workers' contributions to premiums. And look at the gap between that growth and the growth in workers' earnings. So the other thing that we know, practically speaking, is, and this is, by the way, even before cost shift at the point of care or anything else, we know that the gap is widening between what we're asking individuals to do to contribute to their health insurance. Ultimately, at some point in time, we say no mas and we start to look for other alternatives, right? Second thing is, we're now at a point where 20% of all employers are offering high deductible health plans. If you operate a small business, that number is probably 60%, and you are forced to do it. And I love the role of the health insurance. Do we have any health insurance agents? I will offend multiple people, but I love the health insurance agent, right? So my renewal date is in November. They come in the middle of September. They schedule a lunch meeting with me. We go to lunch. They say, I have good news. We've been able to keep your premium increase to 12.5% this year. Okay, well, tell me a little bit. Your census went down. Your spending went down. And we raised your deductible on both family and individual by $200 and $100 each so that we could keep you right in range at 12.5%. And then, they don't even pick up the lunch tab. So, I mean, it's sort of like, what is wrong? What is wrong with this picture? But small businesses are forced to go down this path. And small businesses, frankly, are least equipped to help their employees deal with this, substantially higher financial burden. A young person that has $1,000, $2,000, $3,000 deductible, that's a challenge, right? Now, if you're a silver or bronze, and don't quote me, I'm not an exchange expert, but if you're a silver or bronze on the exchange, you're going to have a $3,000 or $4,000 deductible in addition to your premium. So this creates a big challenge. And this is the result, and this is sort of an ugly four-blocker. This is from my friends at Availity, and they just did some research and a survey, and the research is really disconcerting. Half of all U.S. bankruptcies are tied to medical debt. We're now seeing a trend that was precipitated in Q4 of 14. We heard a lot from our clients, and we read a lot about it in the literature. Not only were people not paying their bills, their self-pay bills, but people were deciding to forego care based on the expectation that they would have to pick up the tab. That's not necessarily a good thing. Only financial acuity, financial acumen, only about 14% of Americans understand these concepts. That is alarming to me, okay, when we have this kind of debt. And once the pay status of that financial obligation goes to what the providers call bad debt, there's only about a 15% recovery rate for providers, okay? So in other words, you'll hear hospital CFOs, and I'm sure there are some in the audience, who said, you know, my self-pay, i.e. I mean my bad debt, my no-pay obligation might double this year, in a world where hospital margins are 3, 4, 5%. That's the entire margin plus. Problem number 3, the public sector programs are crowding out the private payers, and they are in a lot of trouble. And this is a chart. That bright red line is cost, 100% of cost. The green and the blue are community hospital reimbursements by the Medicare and Medicaid programs collectively through 2013. And the yellow lines, that's the dreaded commercial payment line. And you'll see the subsidy that the public sector payers require from the private sector. And again, the yellow, those are the folks that we hate. But thank God for those payers. Thank God for us, right, subsidizing this incredibly inefficient entitlement system. Now, I'm not saying we shouldn't have an entitlement payment system. I'm saying we shouldn't burn money, right? We have to hold those programs accountable and change that game. And here's just one slide, a growth in the Medicaid enrollment and expenditures. By the end of this decade, folks, get this, by the end of this decade, Medicare will be a $1 trillion program, and Medicaid will be about $850 billion. Our entitlement programs will be almost $2 trillion programs by 2020. That's alarming. Problem number 4, we can't do with, death taxes, right? We can't do anything about demography. By 2025, the Medicare program is going to grow rapidly. I think we've got 43 million aged Medicare recipients right now. We're going to go to 70,000 by 2020. But here's the problem. This is the quintessential Pareto condition. We've got 11 million Medicare recipients today that are consuming 55% of all health system spending, okay? They're seeing 13 physicians. They're doing about 50 drugs. And they're doing about 150 visits a year in that population, 150 encounters a year with a clinician. And if we don't figure out how to manage that chronic part of this business, that's an immediate need that we have to sort of solve right away. Number 5, the system is not safe. As I tell people, unfortunately, who might have a terminal or illness or be in really bad shape, I would suggest you skydive, bungee jump, jump off a building, do anything safer than go into a community hospital, because the chances are you will not survive. And, the sad thing, and unfortunately in bad taste today with what happened in France, but I think the call out on this thing is Allstate was trying to call out the problem of teenage driving. We don't really hear a hue and cry about healthcare fatalities, right? We don't have this dialogue. There's some press. David talks a lot about the airplane discipline in that analogy, but there's not a lot of discussion. You can see the array of calamities, deaths, hospital-acquired infections, adverse drug events, et cetera, all kinds of challenging things. 6th problem, intractable problem, one significant part of our system, hospitals. Hospitals consumed $1 trillion last year, $1 trillion. Hospital margins on average, 3.1%. Almost 15% of hospitals are in a negative operating position. Hospitals have only really one way to access capital. It's through the debt markets. If they don't have great financial statements or great balance sheets, they can't really access the debt markets, and we're going to see a lot of pressure on hospitals. I think there are in the neighborhood of 5,500 community hospitals in this country. We need, I'm sure, some number less. But nonetheless, the reality is we are where we are, okay? And this is going to become a challenge. And what we hope doesn't happen, and I will say to you all, if we wake up at this is the 15th, if we get here on the 17th Pop Health Colloquium, and I can barely say that word, and we have learned that all we did was watch big hospital systems get bigger, I'm sorry to offend, we will have really lost this game. Okay, if all we're going to do is drive consolidation of hospital assets, I'm really concerned about that kind of outcome. This was a Robert Wood Johnson study at the end of the 90s that showed, or the early part of this decade that showed at a minimum 5.5% growth in revenues in markets across the country after hospital consolidation, price growth. On the left is something that really is starting to tick people off. It's called site of service differential. So I went to my cardiologist when he or she was community-based. They were acquired by the hospital. I paid one amount. They're now at the hospital. I go to the hospital. I have to pay for parking. It's really inconvenient. I get two different bills. The bill's higher than it was, and I don't think the service is any better. This is un-American, I think. Maybe. I don't know. That's a strong word, but it's un-American. All right. So what are some bright spots? And let me run through these things. This is I don't want to stay on this a lot. This is a very busy slide, but basically this is the value-based care wheel. Now, the thing that I like about this, and you can't really read this, but basically this is, I tell people, all of the things that we have to do in the field on the ground before traditional health plan utilization management, there's a lot of stuff that has to happen, right? And there's a lot of things that focus on chronic populations and on ambulatory populations, and I think we can start to fit into this wheel activities that we would do with the walking well and the ticking time bombs, right? But the idea is that these are all of the things that we should be thinking about. I'd like to set this as a frame because as things go, all healthcare is local, but we ought to be thinking about this at an ecosystem level. And I have a friend who's going to be on the panel later today, Bill Streck, who was the CEO at Bassett for a long time. Really fantastic system. And when I met Bill, I said, what's the total market size? And he looked at me a little bit and he said, market size, and we started talking about this. Said, well, in your primary, secondary, and tertiary zip codes, how much healthcare how much healthcare spend is there? And ask yourself, could you answer that question if you're a hospital CEO? We have to start thinking differently about how we really go about this. And some people are, and there are some sentinel drivers. David, you hit it on the head yesterday. I mean, these are big things for Secretary Burwell to come out and say, by 2018, we're going to have 50% of the Medicare payments in alternative payment models. We just got the guidelines out for ACO. Again, I told you I don't like ACO, but nonetheless, we're seeing a capitated model ACO. We're seeing this activity foment. We need Medicare. We need the public purchasers to foment this activity. Frankly, we need them to drive, in my estimation, more privatization. That will accelerate the market around delivery system reform because most of the market that wants to reform the delivery system doesn't have access to capital. Read, physicians and entrepreneurs need access to capital. They need OPEX and they need CAPEX, and this is a way to start sort of driving that. I borrowed this from somebody, we've cited this, but who would have thought Medicare would fund on a cash flow basis chronic care management? Isn't this fantastic? Isn't this novel? Not that the provider's going to get ultimately $40 and they need some help and it might be a little bit of a heavy lift, but this is a phenomenal sea change in terms of what's happening out there. I do think employers are starting to drive this change a little bit, and I'm going to talk about Walmart and CalPERS in a second. I just read that IBM is starting to make hiring decisions based on markets where they can be a more efficient purchaser of healthcare services. So now it's easy if you're IBM because you have multi-market exposure. But the notion that we're going to hire employees in select markets because those markets are more efficient, think about the competition that creates in those markets to drive a more efficient delivery system. I love what Walmart did here, and Leah Bender, who's not typically a fan of Walmart, came out with an op-ed after this happened. I thought it was absolutely dead on and fantastic. Walmart was alarmed at the cost of transplants in their population. They offered a voluntary second opinion and a treatment program. But what they found was really startling. The folks that availed themselves of that program figured out ultimately that in 40% of the cases where there was a primary recommendation for a transplant, it was deemed to be medically unnecessary. Now, I don't know what's worse, being one of those folks that was identified or being somebody that works at Walmart that had a transplant. Troubling in either case. And then, of course, CalPERS, the California Personal Retirement System, big purchaser, was looking at the variability in joint procedures, found that they were paying providers between $15,000 and $110,000 for the same procedure with the same outcomes. And I love what Dean Nash says, no outcomes, no income, right? No, I think that's trademarked. So every time I say that, I have to pay the piper, but I like it, so I'll keep saying it. But it's true, right? So they said, well, we can really impact this. We're a huge purchaser. Let's do some market research. Let's set what we deem is an appropriate reference price. Hey, what does this remind you of, folks? This is, I hate to say it, this is Ira Magazine, or this is Elaine Enthoven. This is reference pricing. Okay? This is, let's identify a good market price and tell people if you want to pay more, it's a free world. You are more than happy to pay more, but if you need to consume more than $30,000 of our resources, we're going to require you to share 50-50 above the 30 point. Okay? And when they deployed this, what did they find? They found that the average price, surprise, the average price decreased in a very rapid period of time by 37%. They also found a de facto narrowing of networks when they did this. A couple of other things, and again, this is not promotional. I have no stake in any of these organizations, but when we talk about top of license and we talk about the ability to disrupt care, we think about models like these primary models in retail as an example, or work-based primary models, and look at the savings. We want to keep people appropriately out of the ED. There is an appropriate role for the ED. There is a hyper-appropriate role for the acute care facility. The key is discerning, right, at the point of referral or at the trigger, discerning where those appropriate areas are and creating incentives, right, because the consumers oftentimes will also be in this role. And just to use MinuteClinic as an example, this is really predicated on predictive diagnostics. I mean, if there are 30 things on the board at MinuteClinic, you better believe that they know beyond a shadow of a doubt that in all 30 of those cases, they can 100% predictively diagnose that ailment, and they know how to treat it, or it won't go on the board because it won't fit their business model. This is innovation, folks, innovation at work. Who knows what that is? Shouldice in Toronto, right? The #1 hernia repair acute hospital in the world. So Reggie Hertzlinger has been talking about Shouldice and others for a very, very long time, but there is a role for focus factories in terms of delivery reform. Why does every hospital have to have every program? How is it feasible that every community hospital has 10 centers of excellence? Were they consulted by Garrison Keillor? Is everybody above average? I mean, what the hell is going on here? Let's get focused, right? Let's work now. Now, let me just say this. In this focus factory deals with everything related to hernia or complications. It's not just hernia, but it's very important. And, of course, Devi Shetty, Mother Teresa's cardiologist, who's started Narayana Hospital in India, running a very unique model, 24/7, 365, raised a lot of money, coming soon, and might be in the Caymans now, but building facilities all over the place. And, oh, by the way, contracting with U.S. payers. So you can now fly to Cayman, have your heart procedure, stay there for a month, convalesce, have a wonderful, wonderful recovery, and the insurer and your employer will spend about a third of what they would spend to send you out of place in the U.S. with much better, by the way, much better outcomes in many cases than our averages. Lastly, and just as an example, and I didn't really spend a lot of time talking about this distributed ecosystem, but I just want you to think about how the economics change when a device maker that drives clinical information can drop that information into the workflow in a way that can change or avoid a bad event. So a pacemaker that can generate, using a radio frequency device, generate real-time clinical information that identifies an AFib event that helps us avoid stroke. That has the compelling interest of a system-level buyer as opposed to the material manager who's trying to get them, rightfully so, to the best and final lowest price that they can possibly get to. So in closing, I've never been remotely on time any time in my life on any speech, so I'm close. I need to go at least 15 seconds over. What are the implications for this post-industrial world and actors? We desperately need business model transformation, and I would love to talk with folks about what that means, but it really means reorienting your provider organization and other organizations to drive this. Entrepreneurs are important. Physician entrepreneurs are really important. They are out there, but it's important for us to cultivate and foment them. And again, we need to encourage this garage movement and the social enterprise movement and a whole number of other things to rally around this system. We need to embrace transparency, which hopefully I've identified some of the transparency headwinds. Payment models are so critical. Hey, payers, if you want to support independent physicians that have innovative ideas, help to front end some of the cash flow, okay? I talked to a payer, prominent payer, about a year ago, and I said, you need to help independent physicians. And they said, well, we give them a lot of data. Well, I mean, that's sort of an asinine response, right? Let's help these folks help you, because what do we know now from data? We now know from data that independent, non-hospital affiliated primary care physicians in their cluster of care generate lower overall medical trend than those that are hospital affiliated. Get capital into the hands of entrepreneurs. And folks, we have never been at a better time at the intersection of do good and do well in healthcare, and I'm just really excited to be a part of this and to be a part of Dean Nash's program. To be continued with our crew, we have a panel discussion at 1 p.m. today led by my colleague Stephanie Kovalik. Thank you all so very much, and have a great day.